Hi, and I just want to welcome everyone. My name is Stephanie Haynes. I'm the director of Philadelphia Family Pride. We are the LGBTQ parent group in the greater Philadelphia area. And we have LGBTQ parents, prospective parents, grandparents, and our kids of all ages in our group. We hold social events and educational events like this one throughout the year, and are hoping to get back to in-person events when we can. So I am going to introduce Adrian. Adrian Shanker is the executive director of the Bradbury Sullivan LGBTQ Community Center, and that's in Allentown, and is the editor of the critically acclaimed new anthology, Bodies and Barriers, Queer Activists on Health. Book Riot actually listed this book as one of the 6 best books addressing healthcare system inequities, and NBC News named it one of the top 10 LGBTQ books to watch out for in 2020. Adrian also serves as a commissioner and health committee co-chair for the Pennsylvania Commission on LGBTQ Affairs. So I'm going to turn it over to Adrian. I'm going to drop the link to the book in the chat, so if you be sure to check that out. And yeah, so feel free to ask questions, put stuff in the chat, and I'm turning it over to Adrian now.
Thanks so much, Stephanie. You know, I've always really admired Philly Family Pride because there's just such a resiliency when there's a group of parents coming together to advocate for their kids, coming together to advocate for each other, and so for many years I've really admired the work of PFP. I'm Adrian Shanker. I live in Allentown, Pennsylvania, and this is my new book, Bodies and Barriers, Queer Activists on Health. If we were in person, you would get to see me with a stack of books. So I'm just holding it up so that you can see it now on this, this Zoom space. This book is a collection of essays by LGBTQ people across the world. So there's 26 authors who are sharing their stories. And what's unique about this book is that it's LGBTQ people speaking for ourselves. Most of the literature about LGBTQ health is written by researchers or healthcare professionals about us, but it doesn't allow us to tell our own stories. And I'm going to try to focus the conversation tonight on issues that I think fit with PFP's mission and goals as well. Just by way of access, I'm a white queer man, and I'm sitting in front of plants that are behind me in my little Zoom box. I use he, him, his pronouns, and I'm wearing a black shirt. So it's nice to meet all of you. And also for access reasons, if it's easier to see me, you're welcome to pin my video or have it on speaker mode if you'd like to see me on a larger screen. I'm going to start just by sharing a little bit from the introduction of the book, and then I'm going to read a couple excerpts from some of the other authors who I think that their stories will really relate to all of you. And then there'll be time for discussion and questions as well if there's questions that you'd like to ask or to talk about. I'm a full-time queer activist leading an LGBT community-based nonprofit organization with a focus on LGBT health equity, and it happened to me too. By it, I mean a negative experience with a healthcare professional because of my queer identity. I made an appointment with a dermatologist for a baseline screening for skin cancer, but at every turn, the doctor's well-intentioned team made me question if I should be there at all. The intake forms were unnecessarily restrictive. Biased news programming was on full display in the waiting room. Magazines in the waiting room didn't cater to patients like me, and comments from clinic staff displayed brazen cultural incompetence. I didn't go back for the doctor-recommended follow-up. I'm privileged with health insurance, access to private transportation, and the ability to take time away from my job to drive a distance for a medical appointment, so I was able to find a new LGBT-inclusive dermatologist an hour away. For many other LGBT people, the geographic barrier to accessing culturally appropriate care from a specialist might be too great a barrier to overcome. Throughout our lives, LGBT people experience unique structural barriers to care that lead to higher behavioral risk factors for numerous sexually transmitted and chronic diseases. When compounded with past negative experiences in healthcare settings, including outright discrimination, the LGBT community experiences worse health outcomes than the majority population. A 14-year-old youth program participant at Whitman Walker Health in Washington, D.C., shared that wellness is about surviving in a world that wasn't made for you. That's what LGBT people have been bravely doing for decades. Surviving conversion therapy, surviving family rejection, surviving discrimination. To be sure, not everyone survived. No book on LGBT health is complete without a conversation, an acknowledgement of the pain, the loss of a generation to AIDS, the loss of 49 queer lives at Pulse, the loss of so many queer bodies to homicide, suicide, substance overdose, and hate crimes. And with acknowledgement of pain, we should acknowledge that survival is a privilege, that the chances of survival are higher for white, higher income cisgender men. Those of us who survive our unfair landscape persevere through barriers at every step of the way. Barriers created by the pharmaceutical industry, by the medical establishment, by the government, barriers by insurance companies. We live with increased tobacco, alcohol, and other drug usage. We live with increased risk for obesity and diabetes. We live with increased risk for chronic diseases, including HIV and cancer. We live with increased discrimination, violence, harassment, and bullying. We live with family rejection and minority stress, and we are demanding that our healthcare system respond to our lived experiences with culturally appropriate care at all stages of our lives. So again, that's from my introduction to the book. That's a little bit of my own story and the reason that I put this book together. I'm going to share a couple different stories from LGBTQ people and kind of from the broader community. This book takes you on a journey through the lifespan. So it starts with conversations about LGBT youth. One of the first chapters, for example, is about intersex, informed consent for intersex children. And the last chapter in the book is about bereavement support. So it really takes us on a journey through the lifespan. And I'm going to share just a couple of the stories. This one is Elisa Bowman, who's a parent of a transgender child. And Elisa is also the co-author with Michelle Angelo of the book Raising the Trans Child. And this is a little bit of Elisa's story about navigating pediatric care for transgender youth. Elisa writes, "When I learned that my second grader was transgender, I found myself explaining who my child was over and over again to a long list of people, my parents, my husband's parents, my siblings, extended family, teachers, administrators, friends, parents of my child's friends. It went on and on. One person I didn't bother to tell, my child's pediatrician. I ghosted him instead. At the time, I didn't even know why. I'd never heard anyone in that particular doctor's office say anything offensive, yet I just couldn't shake the feeling that my son's first doctor would either be completely uninformed, best case scenario, or openly hostile, worst case scenario. Now, years later, with the benefit of hindsight, I know precisely what made me uneasy. It had nothing to do with what my son's doctor said or did. Rather, it had everything to do with what he did not say or do. Talk to us about our child's gender. My trans son had never behaved, presented himself, or carried himself like a typical girl. By second grade, his short hair was nearly buzzed and he wore ties and only allowed me to shop for him in the boys section of the department store. His hobbies centered on watching World Wrestling Entertainment, memorizing Pokemon characters, and playing Bakugan and kickball. His transness was on full display and loudly noticeable to just about anyone with the slightest inkling of the science of gender diversity. During several doctor visits, I'd even mentioned telling signs, how my child refused to go to the bathroom at school, for example. There had been plenty of openings, yet our pediatrician never once asked us questions about our son's gender, nor suggested that our child might be trans. It was akin to treating a child with high blood sugar and never once saying anything to the child's parents about type 1 diabetes. So I ghosted him. I just stopped making well visit appointments. Instead, for my son's medical care, I began traveling well over an hour to an LGBT clinic where a transgender provider had a growing practice that included dozens and dozens of trans youth. As soon as I walked into the clinic, I knew we were home. Pro-equality stickers and messages decorated the office. Intake forms asked about our child's pronoun and chosen name, and not a single person misgendered him. A social worker interviewed us thoroughly, gently, and confidently, asking a series of questions about my son's previous doctor had either been too embarrassed, too inept, or too dismissive to broach.
The whole atmosphere felt warm, safe, inviting, and comfortable. At our former provider, my son had been mostly shy and silent, answering his doctor's questions quietly with only a few words. But now with his new provider, he bloomed. He chatted comfortably and easily with his new doctor and even began participating in his care with a new level of interest. We were in good hands. So that's a little bit from Elisa Bowman and her story about navigating care for a trans child. The next story that I'm going to share is, really about becoming a prospective parent, really being a prospective parent, becoming a parent. It's about family building for LGBT people, especially LGBT young adults. And I know that this is a topic that's frequently discussed within Philly Family Pride community. The author of this chapter, her name is Kate Luxian, and actually their name is Kate Luxian, and they live in London. And this is a chapter about how queer family planning provides a remedy for depression for queer young adults. Kate writes, "Like most queer people, I don't have a fairy tale family. There is a prince for each princess and no substitution. Fairy tales and family units have a socially ordered progression of love, then marriage, then babies. But this progression is stymied by stigma, which shrouds both unmarried and married LGBT youth and young adults, labeling them socially unfit for the role and title of parent. Rather than heroic achievers, queer young adults are relegated to cautionary tales without rhyme or reason, or a consideration of agency or diversity in family constellations. Growing up in the United States presents a very specific picture of who is considered a valuable member of society. Race, social and family standing, sexual orientation, gender identity, among other categories, are intricately woven together into unique identities and experiences. Despite the beauty of innate human diversity, the personification of model citizen is most often white, able-bodied, Christian, middle-class, cis men, attracted only to cis women. Companionship then becomes limited to similar race and social standing, with children brought forth through medically unaided reproduction. Kinship and genetics are often inseparable in legal and medical definitions, reliant on upholding the cisnormative, heteronormative models of family. Queer pregnancy, adoption, surrogacy, and blending families through marriage have been met with bigoted statements disguised as curiosity, questioning queer parents about, quote, the real mother and father. Traditional narratives leave out same gender and gender diverse family making and keep us from an accurate telling of humanity's reproductive potential. Despite the evidence around LGBT parenting, social narratives and medical and legal barriers still limit access to inclusive sexual and reproductive health services. To make improvements, the following recommendations can reduce barriers while opening spaces for LGBT young adults to discuss parenting and reproductive health. Discussions around family planning for queer young adults have to begin before puberty. LGBT children, teens, and young adults are failed brilliantly by institutional structures teaching about sexual and reproductive health. The value of queer sex ed goes further than knowledge about sexual health, as a lack of knowledge can result in infertility. STDs such as chlamydia can strip the body of fertility regardless of the presence of symptoms. For trans youth seeking medical care as part of gender affirmation and general well-being, the discussion of family planning should be presented as a possibility to explore their own agency and provide access to a self-defined future. Centering fertility in diverse bodies presents a more realistic picture of reproduction, regardless of sex assigned at birth, sexual orientation, or gender identity. Trans children and youth should be able to access mainstream representations that allow them to retain reproductive agency while seeking affirming care. The complexity of family structures is not limited by legal partnerships, with some biological children being born to couple pairs who choose to co-parent. Legal barriers make queer family planning more complicated on paper and in legislation than it is in practice. On the non-medical side, caseworkers and mental health practitioners serve an integral role in the process of fostering and adoption for queer families. Some queer young adults may be referred to a clinical mental health practitioner when seeking assisted reproductive technologies. These referrals are rooted in outdated, offensive practices meant to deny care to LGBT parents-to-be. As the understanding of families and kinship expands to include all of us, the limitations of the current conservative systems become clearer. Biology is not the absolute anchor of kinship, and we will not absolve institutions of bigotry when they use this as their crutch. Families are defined in a myriad of ways, picking up momentum as access and acceptance expands. Whether blended, biological, adopted, chosen, or any variation thereof, a family is made in many ways and should be supported and respected legally, medically, and socially. When we do so, we ease the depression plaguing queer young adults. The next story I'm going to share, a second to last story I'm going to share, is by Liz Margulies. Liz writes about cancer. And cancer is something that, all people think about at some point in their life. But Liz writes about how gender relates to cancer. And this is her story. I should say that Liz is the founder of the National LGBT Cancer Network and lives in New York City. Liz writes, I don't have cancer so far, and that's a good thing. But over a 10-year period, I accompanied 4 queer women to the edge of the cancer cliff and then watched them all tumble over it and die. These were not just 4 people I knew and lost. They were 4 of my favorite people on the planet. Adria, Ruth, Joe, and Shirley all died of ovarian cancer in their 50s. During that same decade, 3 other friends were treated for breast cancer. What are the odds of this? Slim, I would have thought. But it turns out that this massive loss is not the product of bum luck or a poor choice of friends on my part. This is what health disparities look like in real life. When I was forced to understand this by falling face first into my grief and rage, I set out to tell the world. I was in my 50s too. Please don't pull out that inaccurate trope that says that cancer doesn't discriminate. I've heard it way too many times, and I've lost my patience with explaining, yes, rogue cells are rogue cells, but we can't tease out the lives of the errant cells from the social conditions in which the whole body lives. The stress and stigma of living as a sexual and gender minority in this culture absolutely contributes to poor health outcomes. For example, my community uses tobacco, alcohol, and other drugs at substantially higher rates than the general population, all coping strategies. And as a group, lesbians and bi women are said to have the densest cluster of breast cancer risks, increased tobacco and alcohol, lower likelihood of having a biological child before age 30, and higher incidence of obesity. Then, instead of being hypervigilant about cancer screenings, LGBT people avoid the healthcare system due to substantially lower rates of insurance coverage and previous negative experiences in hospitals and doctors' offices. Our cancer screening rates are dismally low, especially for trans and gender nonconforming people. It's highly probable that our community has a higher incidence of cancer given the increased risk factors and decreased screening rates. But since no national cancer registries actually collect data about sexual orientation and gender identity, we remain buried in the vast data on file. Just as psychology is not the unbiased science of mind and behavior, oncology is not a medical and unbiased science of the diagnosis and treatment of cancer. I learned that cancer treatment is profoundly gendered. To claim it's about science and surgery and chemotherapy, all neutral terms, is to miss the gendered environment in which the treatment is offered and the impact of the treatment on one's felt sense of gender. One's sense of gender also shapes the cancer treatment decision-making. Let's look at breast cancer as an extreme example, where treatment nearly always includes surgery. Losing one's breast partially or fully by choice or necessity can change one's embodiment of gender. For trans cancer patients, the option of bilateral mastectomy may be perceived as gender-affirming surgery. A butch lesbian may welcome the option of smaller breasts, but may not want to be perceived as trans by going flat. And a young femme-identified patient may choose reconstruction. In nearly no cases are healthcare professionals tuned into this gendered aspect of medical decision-making. They're therefore not able to help patients choose the best surgery for their lives, not just their health. Still, despite pressure from surgeons to elect one of multiple types of breast reconstruction, more and more sexual minority women choose to go flat. While some prefer to live without breasts, others are willing to do so rather than to have multiple surgeries to construct new breasts, each carrying some risks and longer recoveries. The same goes for hair. Many chemotherapies cause hair loss. How women choose to handle baldness is one of cancer's largest challenges. It's a primary signifier of femaleness. Here too, I found that many sexual minority women forego the use of wigs, choosing to expose their baldness or wear baseball caps. This impacts their sense of felt gender, as well as the way they are perceived in the world. I wonder sometimes what it will be like for me to have cancer. Will all my professional work and research serve to make my cancer experience less stressful? Is forewarned, forearmed? Will I be bolder in my demand for the respect and care I want from both my provider and the healthcare system? What if I'm forced to choose, as many are, between using the best doctor, who's an asshole, or the young, more experienced queer doctor, less experienced queer doctor? What will I do? Most probably, like everyone else, I'll wing it. I'll bumble, I'll cry, I'll be afraid. I'll forge on, one way or another. I'll lean on my friends for support. I'll be tired, I'll be angry. I'll experience cancer like I experienced the world, as queer, as a woman, and as white. My experience will be gendered, but my experience will be mine. The last chapter I'm going to share before reading a little bit from the afterword is from Robin Oakes. Robin is an amazing bi activist in Boston and the editor of Bi Women's Quarterly. And Robin shares experiences, bi people's experience with healthcare professionals. Robin writes, "My name is Robin Oakes, and I've identified as bisexual for 42 years. I'm an educator, advocate, and healthcare consumer. What do I want my healthcare providers to know about my experience as a bi-identified person accessing healthcare? First thing I want them to know is that even after all these years, the thought of telling a healthcare professional that I identify as bisexual fills me with anxiety. I know that the word bisexual carries a lot of stereotypes. I'm afraid they'll very likely make assumptions about me based on that one word, even if these assumptions are not true. I'm afraid that as a result, they might not provide me with the best possible healthcare. I'm afraid they might give me the look. You know that look. It's the one where your body contracts a little bit. You're suddenly no longer making full eye contact with me, and you look like you just swallowed something unpleasant. Are my feelings based on actual bad experiences or anticipated bad experiences? Yes, both. Here are two stories from my own life. When I was in my early 20s, I was confused. I was confused about just about everything except my sexual orientation. I'd already identified as bi for several years, and about that I was 100% certain. But I was confused about how to operationalize my bisexuality. There can be an enormous chasm between knowing and being. While it was clear to me who I was, I didn't know how to be a bisexual person in a binary, heteronormative, and homophobic world. It was clear to me as a bi-identified person, I would not be fully welcome in mainstream society, nor fully welcome in lesbian and gay circles. I was also confused about my career. I was confused about my relationship with my family. I was confused about how to maintain a healthy and successful romantic relationship. I felt tentative and bewildered, confused. In search of clarity, I decided to see a therapist, and I found one on a list provided by my HMO. I saw this therapist weekly for 4 months. Not once did I mention my bi identity. I was afraid. I had no idea what she thought of bisexuality, whether she even considered it a valid, enduring identity. I was afraid she would think I was a lesbian who just hadn't finished coming out. I was afraid she would try to make therapy about my bisexuality. I had heard from other bi friends that their therapists had done such things to them. I was worried that this would happen to me too. I could have used some help working through that anticipatory fear and figuring out how to come out and exist in the world as a bi person, but I was too afraid to come out to my therapist. After 4 months, I terminated therapy, having wasted my time and money and her time. 2 years later, I decided to try again. This time, I selected a therapist who had a connection to Boston's emerging bi community and who I knew identified as bi. By choosing her, I could be certain that my bisexuality would be seen as simply one aspect of my identity. I could be certain she would not try to help me, quote, finish coming out as a lesbian. It worked for me. I worked through a number of issues with this therapist. She understood the challenges I face as a bi-identified person because they were her challenges too. She got it. Second time's a charm. Also in my 20s, during an annual checkup with a new primary care physician, we had the following conversation. Physician, are you sexually active? Me, yes. Physician, what kind of birth control do you use? At the time, I was in a monogamous relationship with a woman. I wanted to reply flippantly, we use the lesbian method, but I wasn't that brave. I hemmed and hawed and squirmed uncomfortably and finally managed to state that my partner is a woman. It was awkward and uncomfortable. A couple of years later, that relationship had ended, and I was in a new relationship with a man. I suspected that there was a note in my chart saying I was a lesbian, and I finally awkwardly told my doctor I'm bisexual and got fitted for a diaphragm. Is it just me, or are my experiences commonplace? Are my experiences unique? Yes and no. but mostly no. What do bisexual people want from their healthcare providers? The Advocate sums it up by saying, I'll see my doctor in a few weeks for a routine visit. I'm glad I'm out to my provider. We'll talk about my sex life openly, freely, and without judgment. I'll get the results of my routine HIV and STI test for my last appointment. I'm confident the results, whatever they may be, will be delivered with care and compassion. At the end of the day, that's what any bisexual person, any LGBTQ person, and any human being deserves. Access to an affordable, non-judgmental medical provider who will offer and provide tests as requested and needed without wincing or clenching when we are honest with our providers and ourselves. So that's Robin's story. And I'm going to finish up before we go to questions with just sharing from the afterword of the book. The foreword of the book, by the way, is written by Dr. Rachel Levine, our brilliant and amazing Secretary of Health here in Pennsylvania. And she writes about being a trans woman who's accessed healthcare, a physician who's provided care to LGBTQ patients, and a policymaker who's made health policy decisions that impact all people, including LGBTQ people. But the afterword is written by Kate Kendall, who's one of our movement's heroes, really, in every way. She led the National Center for Lesbian Rights for more than 2 decades and is one of the country's most prominent litigators for marriage equality. So here's Kate's conclusion of the book. Throughout my career, I've been involved with some of the LGBT movement's greatest fights. Marriage equality, non-discrimination in the workplace, parenting rights, inclusion in sports, ending conversion therapy, protecting youth, elders, and LGBT families. The common thread that links all these issues is health and well-being. It's not possible to be a healthy, vital person if you're under assault for who you are. Precisely because so many LGBT people struggle with stigma, safety, acceptance, and belonging, many in our community still struggle with high rates of mental and physical health challenges. Despite the odds, our movement for LGBT liberation has come far. In my 22 years leading the National Center for Lesbian Rights, I had a front row seat to our national progress. Out of nothing and in the face of hostility from our own government, we built the HIV/AIDS infrastructure in the 80s to fight back, save our men and everyone impacted by the pandemic. When I started at National Center for Lesbian Rights in the 90s, LGBT parents routinely lost custody of their children. Now sexual orientation is not a basis for losing custody. In the early 2000s, many openly wondered if we should fight for the freedom to marry or if such a fight would be successful in our lifetimes. In 2015, we won marriage nationwide at the Supreme Court. We've come a long way from the time when LGBT people were dying left and right from a treatable virus to witnessing some of those early AIDS activists marrying longtime partners. The LGBT community still experiences open hostility and disregard from healthcare professionals. LGBT health needs are still not covered equitably by healthcare insurers, and policymakers still lack the political will to advocate for equitable policies for our community. From obstetricians refusing to treat lesbians to gay men being ridiculed for wanting a prescription for PrEP, healthcare professionals can do better, policymakers can do better, all of us can do better. Our movement for equality, for liberation has been breathtaking in its gains, but we still fight for our humanity, our health, and our happiness. The priority for a new generation must be the health of every one of us, the promise of a long, healthy, and fully embraced life. So that's Bodies and Barriers, Queer Activists on Health. These are essays from 26 queer activists from around the world. And really, I can sum up this book in one sentence by saying that, without our health, we don't have our lives. LGBTQ people deserve health equity. We don't currently have health equity. It's a dream that's not realized, but it's a dream that we can keep fighting for. There's nothing biologic about LGBTQ people's bodies that prevent us from achieving health equity. These are social problems. That means that they're also fixable problems if we work for it. So that's a little bit from this book, and I'm happy to answer any questions. You're welcome to either unmute yourself and ask questions, or ask a question in the chat if you would like to ask that way. And there is already one question about if I can talk about the impact of COVID on LGBTQ folks versus the larger population. So yes, so COVID unmasked the existing disparities that already were harming LGBTQ people. But LGBTQ people also know this was not our first virus, and we know something about how to survive a plague. We can take the lessons from, the ACT UP activists, the TAG activists that taught us how to fight for our health. This pandemic is very different than HIV/AIDS, and we can't draw a moral comparison. They're very different, but we can learn lessons from activists who came before us. One lesson is the importance of data. Another lesson is fighting for knowledge and information, and to prioritize knowledge and information for our community. So a couple things. So first, we know that LGBTQ people live with increased risk factors for COVID-19. We consume tobacco at double the rate of the majority population, and current smokers are 2.5 times more likely to experience the worst effects of COVID. We also, many more of us live with cancer or unsuppressed HIV than the majority population. And early in the pandemic, people were saying things like, if you get sick, call your doctor. But 1 in 5 LGBTQ Pennsylvanians doesn't have a primary care doctor. So who are we supposed to call if we get sick? The answer has to be that we need to separate access to care from access to healthcare insurance. We need to make sure that care is provided, routinely and regularly. We also need to make sure that data is collected about LGBT health. In May, Secretary Levine became the first Secretary of Health in any state to mandate data collection for COVID-19 infections related to sexual orientation and gender identity. And I was really proud to work with her to achieve that policy victory. Just recently, Pennsylvania Department of Health published a sexual health guidance related to COVID-19. Before that, Montgomery County Department of Health, Allentown Health Bureau, Erie County Department of Health, which was the first, by the way, Allegheny County Health Bureau, and Philadelphia Department of Public Health all released sex during COVID-19 guidances as well. So this is information we have to fight for. And one thing we can learn from early AIDS activists is that if we don't fight for it, it's not going to happen. So we have to fight to make sure that LGBT health is prioritized, even during a pandemic that affects our entire community. And by the way, there's a lot we don't know about COVID still, but when I say that this is very different than HIV, here's a couple examples. So, in the early days of HIV, healthcare professionals did not want to provide care for people living and or dying from AIDS. In March of this year, healthcare professionals were heroes. It's debatable if our healthcare system still sees healthcare workers as heroes or if they're back to just being staff, but this is the capitalist system that we live in. But regardless, healthcare professionals were seen as heroes. In the early days of HIV, the president of the United States didn't say the word HIV or the word AIDS until after 5,000 people died. President Trump, for his many, many, many failures with managing this virus, held daily press conferences and said the word COVID right away. Early in the days of HIV, businesses did not rush to change anything. Here today, like this year, we shut down school systems, changed the tax deadline, and manufacturers across the country started to make ventilators and masks. Distilleries started to make hand sanitizer. People rushed to take action. They took the virus seriously. Early in the days of HIV, people who were dying of AIDS were seen as undesirables in community, like gay people and people dealing with drug issues. Today, in the early days of COVID, people were seeing, people dying from COVID as, it could be any of us. It could be our grandparents. It could be our parents. That's just some examples of how this virus is very different socially and culturally than HIV. Ali asks a question, could I speak about, if possible, queer folks accessing and or qualifying for fertility treatments and evaluations? So this is a really important question because one of the most significant barriers for LGBTQ healthcare is that most private insurance, and frankly public insurance, doesn't cover assisted reproductive technologies, which LGBTQ people need. And they have arbitrary and unfair and frankly, I would believe unconstitutional requirements that require 6 months of traditional methods to become a parent, which frequently doesn't work for lesbians in particular. And so, the requirements that insurance companies have put on, where it says you have to have, you have to engage in heterosexual sex for 6 months before we'll cover your fertility treatment. It's not only beyond the pale, but it's blatantly offensive. And advocates can speak up by, writing letters to the Pennsylvania Insurance Commissioner to talk about how unfair this is. It's absolutely unfair, and it's also something that could easily be changed with a mandate from our Pennsylvania Insurance Commissioner. It's also something that insurance companies can change on their own. You can call your insurance company and ask if they cover a certain procedure. Even frankly, if it's something that you don't need, you can still call and just ask if it's covered. If you're an employer who provides coverage for your employees, you can ask the insurance company if they can offer assisted reproductive technology coverage for your employees without that ridiculous 6-month heterosexual sex requirement. And then there's another piece of this, which is more complicated for insurance companies, which is gamete preservation for, especially when we're talking about trans youth. Gamete meaning, sperm or egg preservation. So to be able to, to provide agency for trans youth who, who have medical needs to access, for example, puberty blockers or other gender affirming care, they should still have conversations with their healthcare providers about future interests in becoming a biological parent. And there's technology that can allow for that, but insurance companies frequently don't cover gamete preservation, especially in the instance of trans youth. This is a justice issue. Access to bodily decision making, personal family making. Personally, like I don't see myself wanting to become a parent through assisted reproductive technology. So it's not something I need for my own health insurance. Other people may need it though. And so people should have the right to make decisions for their own bodies and their own lives about what their families might look like in the future. So this is a type of advocacy that's needed by people who care deeply about the parenting rights of LGBTQ plus people. There's a question, and Ali, if I didn't fully answer your question, I'm going to answer Tony's question, but feel free to, ask again or unmute yourself and ask as well. Tony asks, how do we best advocate for LGBTQ plus health issues for Affordable Care Act, or hopefully a Medicare for all, or even a Biden care? So I would just say, first off, I believe that healthcare is a human right. And if healthcare is a human right, then we should have a healthcare system, not a health sales system, which is what we currently have. We have a health sales system. We have a system that says, the best healthcare if you can afford it. The best, if you have access to health insurance, you can afford your care. That should not be the system we have. So I actually believe we have to move to a Medicare for all system. But even within the current system, we should remember first off that the Affordable Care Act provided significant gains for LGBT health. People living with HIV are no longer discriminated against by having a pre-existing condition. Transgender people are not told that they can't get health insurance because of pre-existing condition. This is very, very important. HIV and STI testing is fully covered under the Affordable Care Act. Birth control is fully covered under the Affordable Care Act. Cervical pap tests are fully covered. Mammograms are fully covered. These are justice issues for our community. And so the Affordable Care Act is not perfect. It doesn't go far enough, and yet it is an essential gain for healthcare for the LGBTQ plus population. So as queer activists, I believe we have to fight to defend it and also fight for something better at the same time. And we can do both at the same time. We can say, don't take the Affordable Care Act away, and also we're going to continue to advocate for something more. Regardless of what type of healthcare system we have, Medicare for all is what I believe in, and yet that Medicare for all will not create equity for LGBTQ health. It will not by itself give us health equity. We also need to ensure that medical schools, social work schools, nursing schools, teach more information about LGBT health. We need better training for healthcare providers about the unique health needs of our community. It's not only about access to care, it's also about the training of the healthcare providers. And so both of those have to go hand in hand. We have to have better training on LGBT healthcare, and we need to remove the cost we need to remove costs as a barrier to care. Then the third piece is geographic barriers to care. There's entire counties in Pennsylvania that don't have, for example, a trans affirming therapist or an LGBT affirming fertility treatment specialist. People might have to drive 1, 2, or 3 hours to get care from an LGBT affirming specialist. So we also need to ensure that we have healthcare available in close proximity to us. Folks involved in Philly Family Pride probably live in Philly or Philly suburbs, where you're very lucky to have access to some really great healthcare options that include specialists who serve the LGBT community, from CHOPS Gender Clinic to Mazzoni and Fight, to many, many, many other providers. But in rural Pennsylvania or in many rural counties across the country, that's not the case. So we have to remember that geography is also a significant barrier to care. Ali asks, have I heard of any experiences where the 6-month requirement has been waived? Any suggestions for reaching out to insurance to address this requirement? I've heard of, so I want to answer this in 2 ways. I'm not personally aware of specific insurance companies that have waived it across the board yet, and that is a form of advocacy that needs to take place. I am aware of doctors working with their patients to get it waived for a specific patient, and so that is something that certainly can happen. And folks who are talking to fertility providers, such as in the Philly area, you have Mainline Fertility, RMA, Abington Reproductive Medicine. There are a variety of folks. You can talk to them about if they can help you to advocate with the insurance company. But I would also encourage, please write a letter to the Pennsylvania Insurance Commissioner as well, because it shouldn't be something that requires individual advocacy. It should be something that is just a given, because that's what our community deserves. Becca writes, I'm a nursing student and I want to suggest this book to your classmates, if that's okay. Yes, Becca, please do so. And I'll put my email address in the chat. I invite you to reach out to me, because if there's an interest in you're like a professor teaching it, I'm happy to Zoom in and talk to the whole class as well, or something along those lines. Or if there's a nursing student club at your school, I'll do a talk for the nursing student club or something like that. So please feel free to reach out. Actually, Stephanie, if you would be willing to just throw my email in the chat, that would be really wonderful. And then Liz asks, many of these barriers feel so intersectional. How do we harness an intersectional approach with other populations advocating for healthcare reform? I want to just say yes first, yes, that's absolutely what we need to do. Healthcare is an LGBTQ issue. It's an issue for Black and Brown communities. It's an issue for immigrant communities. It's an issue for women. It's an issue for men. It's an issue for all of us. So this is something that we have to advocate for from an intersectional lens. I would say a couple things though. First, there are some specific issues related to LGBT healthcare inequality that are specific to the LGBT population. That doesn't mean it's not intersectional. It just means that we can't talk about it as a majority population issue without providing an LGBT lens to that advocacy. We have to talk about, for example, how there are counties without trans affirming therapists, right? Or we have to talk about how anal pap tests are not covered by health insurance in most of Pennsylvania. But we can also talk about this from a broad issue. And a good example of that might be telehealth. So in the beginning of the pandemic, Pennsylvania expanded telehealth, but they put a ridiculous requirement that prevented telehealth services from being covered by insurance across county lines, which means that if you live in Potter County and there's no trans affirming therapist in Potter County, you can't get insurance coverage for telehealth services that you need. If you live in Philadelphia, you might have plenty of options. But so, from an intersectional lens, this also really affects other minoritized and marginalized communities. So we should be advocating that telehealth be expanded and the expansion made permanent, and without these arbitrary and ridiculous barriers to care. Another example is fighting for Medicare for all. LGBTQ people benefit from Medicare for all, so does every other minoritized community. So we can advocate for these broad issues from an intersectional lens, and we should advocate from an intersectional lens. And while we're doing that, we should also ensure that we're highlighting some of the specific needs that LGBTQ people experience that are often unmet. Liz, I hope that answers your question as well. If not, please feel free to unmute yourself or clarify in the chat. Are there any other questions, either verbally or in the chat? Okay, well, I want to thank you all for listening and just remind you, so Bodies and Barriers, Queer Activists on Health. This book is published by PM Press, which is a radical independent publisher in the Bay Area. They publish really great radical texts. It's like a great like radical reading list just to go through and see what other books they published. But for me, this book is really important because it centers a conversation that's often unheard, which is LGBTQ people speaking on our own behalf for our own health, because without our health, we don't have our lives. So I encourage you to read the book. Please read the book. If you have any questions, my email's in the chat, and I'm happy to communicate later as well. Thank you so much to Philadelphia Family Pride.
Thank
Stephanie,
you, Adrian.
over to you.
Thank you. Thank you so much, Adrian. Thanks everyone for attending and your great questions. We're going to put the I'll stop the recording in a minute. We'll put the recording on our Facebook page, Philadelphia Family Pride, tomorrow. And I think that's it. Thanks again.